Waseem Sajjad from LRH Peshawar, and he will be nipping the evil in the bud. Let's see what evil he's nipping.
Once again with another case. I'm Dr. Waseem Sajjad, an intervention cardiology fellow in Lady Reading Hospital, Peshawar. The title of my case is Nip the Evil in the Bud. First, I'll give you a brief history of my patient. This is a 55-year-old lady presented to emergency department with severe chest pain for last 5 hours and associated with vomiting only. She had a previous history of hypertension, but she was not taking any hypertensive medications for it. She was vitally stable with a blood pressure of 120/70, pulse was 86 per minute regular, and she was maintaining saturations of 95% room air. Cardiovascular examination and other examination was unremarkable. ECG showed ST depressions in the anterior and lateral leads. Tropi was raised, and echo showed preserved function with EF of 65%. So it was a case of non-ST elevated MI. So we planned her coronary angiogram, and this is the first clip of coronary angiogram. You can see that there is a severe disease in the proximal segment of left circumflex. In this angiogram, the LMS seems to be normal, but there is severe disease again in the proximal circumflex. The LAD in the mid shows a moderate to severe disease, but distally the LAD was total. Again, in this view, you can see the LAD is total from the distal segment. The RCA was a non-dominant vessel, and it was proximally showing severe disease. So we planned her PCI. First, also in this view, you can see this RCA is giving some cross collaterals to the LAD as well, as you can see. So we plan to open the LAD first. We wire the LAD with a whisper guide wire under the support of OTW balloon. The LED was wired, and you can see the position of the distal wire. Later on, we pre-dilated with the 2.5 into 15 balloon. Zion's prime 2.5 into 38 stent was deployed in the mid to distal LAD. Another Promus Premier 320 was deployed in the proximal LAD. Lesion was further, stents were further post-dilated with balloon 3 into 15 in the mid to proximal stent, and you can see post-dilatation. The distal stent was further post-dilated with the NC track 2.5 into 12. So this was the LAD shot. Then we, as there was a severe disease in the proximal circumflex as well, so we tackled it with a BMW guide wire and pre-dilated with a 2 into 15 balloon. But though while negotiating the lesion of circumflex, we just observed some staining in the, you can see some staining from one of the branches of the distal LAD. Probably we're not sure from which particular branch, but though the patient was asymptomatic, but so we continued the PCI of left circumflex. Zion's 3 into 18 was deployed. The flow was a bit sluggish, so intracoronary nitro was given. The flow improved. So you can see the stain in from one of the distal branch of the LAD.
Who's streaming?
So echo was done on table and there was no pericardial effusion. And after 3 to 4 hours, the patient was kept in strict monitoring, and patient became short of breath after 3 to 4 hours, and he was hypotensive. Echo showed large pericardial effusion with signs of tamponade. Immediate pericardiosynthesis was done and patient BP improved. Patient was shifted back to the cath lab, and you can see that the extravasation from one of the distal branches of the LAD had increased. So what we did is that we, in order to confirm this distal apical branch of the LAD, we took a microcatheter to confirm this perforated branch of the LAD. Though that shot has not been recorded, but we took a 2x15 balloon and we cut it in the mid, and its distal part was mounted on a BMW guide wire and pushed on another balloon to plug this perforated branch. I would show in animation later on. You can see that this extravasation is fading away after this cut balloon technique. We checked it in different angles. On third day, though the patient was asymptomatic, on third day we did echo again. It was showing mild to moderate pericardial effusion. So on third day we shifted the patient for third time to the cath lab. And though the extravasation had completely sealed, we checked it again in different angles. So this is what the animated one, we can take a guide wire, and this is the perforated branch. We can take a guide wire, and this green is a balloon, and this cut balloon is blue in color. You can plug it or wedge it in one of the side branch by cut balloon technique. So we did it in this our patient, and it worked. So the takeaways for my today's presentation is that keep an eye on guide catheter and guide wire during entire procedure. A tiny branch perforation can be catastrophic, and be innovative, as necessity is the mother of invention. Thank you.
Can you show the last cranial view of the first procedure?
It's not going to.
And the first view of the second procedure as well. These two views.
Which one?
Yeah.
No. First procedure before attempting the circ.
Last view of your first procedure, and then you, after pericardial effusion, you took this patient to the cath lab and took your first view.
Okay.
This one.
This one?
Yeah.
Previous
one.
Okay. Do you want to make any point if the heart?
इससे भी पीछे जाएं, सर्क से पहले वाला. अभी तो सर्क ये PCI हो गई है. इससे पहले. इससे पहले. इससे पहले. Back. Which wire was used in LED's standing? Back, please.
That was a whisper guide wire.
Okay, back. Previous one. Previous cranial view last. Yes. Please run it.
Okay.
Okay, we cannot see any of the oozing from this view, But if we have seen there was some staining in the initial stages of the PCI to circ. To me, I think we should have stopped at that place, and then we should tackle this thing rather than to go for the PCI to circ, because we have to increase the heparin dose in that PCI. If we could have done the balloon tamponade in the distal LED at that place, then this could not have increased, and I think this catastrophe of pericardial effusion could not have happened.
I think this is one of the option you may think of, because this patient is already under cover of heparin, and just stenting a discrete lesion in stent in circ wouldn't make any difference in terms of that. It was apparently in the later views looking a very minor kind of wire perforation.
Yes.
That's why you think of that it may wean off by itself without needing any intervention. But when to your second view, there was it was extravasation of dye was much more as compared to
Yes.
the one you left with the first. So I think it may exceeded afterward. So sometimes you don't expect this minor kind of leak going to give you that kind of situation. But here what I see, your wire is distality is slightly crumple kind. And once when you're putting one or two stents, sometimes you really off-see your distality. And you try to push in your wire, your focus in on that lesion rather than looking at your and that may be the reason here.
Yes.
So we have to be very careful for your distality of the wire when it's going into small branches, it's curling. Sometimes we say, usually out of like 50 or 100 times, very few of the time you got some complication out of that. But once you get, you may end up with that kind of
Exactly, it
situation.
did seem a bit buckled up, no doubt about it, and that's exactly one of the things. I mean, did we use any balloon support? Was it the wire crossing was easy, or did you have to push it hard? Maybe you took the balloon in deep, and while you were surfing with the wire, did you go into the side branches, which you could easily figure out, and then you had to retrieve the wire and push forward? I think these are some of the maneuvers, especially with these hydrophilic wires, which can make distal perforation a bit more easier than what we think it is. So maybe I think we have.
Now,
excuse me,
can you
to-
show the next views in between? Dr. Jabbar?
Actually, I did this case. One has to be very vigilant during PCI. You have to check the proximal guide because
Sir, your voice is not.
proximal guide to check for dissection and distal wire. So in this case, probably we were a bit casual, and the distal wire had got perforated a small branch. Regarding Dr. Iftikhar comments, initially probably the small branch was perforated and wire was there, so it has stopped the bleeding when wire was there. When we switched the wire from LED to the circumflex, so that it was revealed later on.
One comment.
That's what I thought.
This was a CTO of LAD, so there was very nice collateral from RCA. So to start such cases, it's better to use a dual injection. If it was a dual injection, there's a very rare chance of getting such kind of wire perforation, number one. Number two, there is not a single perforation. I think there's two perforation, one from the circ or some other places. And thirdly, the comments using the balloon, cut balloon to seal it, it is for the side branches, not from the tip of the wire. If it is a side branch, you can use it. Dr. Irfan is there, who started first in Peshawar, and he had a case, and this is second case they did. But it should be from for the side branch, where there's a side branch coming out with a perforation, so it covers the side branch. And in such case, if it is from the apex, and what they did in a micro injection, it is an apex perforation, such balloon will be not helping. So
Exactly.
that will be either coiling or fat embolization, which will help. So
Yes.
my comments about
That's why we have two different algorithms for distal wire perforation and for large vessel perforation, and obviously coiling and fat embolization.
As far as his comments is concerned, that there was 3 or 4 perforation, there was single perforation that we confirmed with our microcatheter. And second, it was a type of side branch, at the epic LED, which was divided.
While
with
we
a
are
very
actually
small
It was a
focused
tiny
on
branch
discussion of
and-
this perforation, we have left few technical things in the decision making actually, and then the execution of the PCIF LED. As we can see that the proximal stance is still in the diseased area, and it's a left dominant system, and there was some impression that maybe
Regarding his CTO, actually, let me discuss the case. The culprit was Sark, because she has end STEMI and LED was CTO. I told my fellows that I will try to, if I could cross it within 5 minutes, then I will do the LED first, otherwise I will do the circumflex. Luckily I could cross it within 5 minutes, so it was a very short segment, so then I wanted to do the
No,
complete
even
revascularization.
you can have collateral and acute on chronic lesions as well.
Yeah.
The way they stented past their wire, it may be LED. You don't have ST elevation because of a good collateral pre-existingly formed because of acute on chronic lesion. And so there are both possibilities are there, that LED may be
And
culprit and
with-
CERC may be a stable lesion.
The new guidelines of ACC 2021 recommend in case of CTO in multi-vessel PCI, if you are doing a CTO in case of multi-vessel, it's better to open the other vessel other than the CTO. But this is the culprit vessel.
The donor
so if
vessel,
they have
yeah.
fixed the CERC, given a time to the patient, and bring it back if it is a symptomatic patient. If it is a non-symptomatic patient, better to leave it, and risking a patient with such without properly protocoling the CTO, I mean, it's something that should
actually,
be done.
Are you
to-
considering LED to be CTO?
I think it must be
Sir,
a
please,
insurance patient actually with limited budget, so you wanted to complete this. So this is,
One last
this
comment,
must not be the scenario in this
Sir,
com-
one last comment. I'm grateful for the animation which was being given to me or made by Dr. Saeed.
It's not lost, Jabbar. I am waiting for long time. Your
And,
comment is not
I'm
the last.
grateful-
I will
I'm-
have the last.
Yes, I'm grateful to Professor Irfan Saab who taught us this technique, and we have done it more than 3 or 4 cases.
it was very well managed actually at the end. It was
Not
very well
actually,
managed.
I am discussing the case, not that thing. That
Okay,
everyone
Mr. Last
knows.
comment.
Actually,
All's well
if
that
you
ends
see
well.
the first, the wire seems to be off the track
Yes.
in the first cine. Then again, the thing was, there was a contained dye which was not draining, so that was probably a contained perforation. What happened that they did the CERC and they gave nitro. With nitro, I think you can see
Yeah, possible.
the thing which was sealed nicely, that started bleeding again. So one thing, CERC might not be that a problem, but what was the problem? It was nitro given for the CERC, which was having distally spasm. So that is one lesson. If one can avoid at that time and stage it for another time, because you may need nitro. You cannot go without. You may need some this 2B3A. So these things may be needed. So that's why if you can stop at that stage and
Yeah.
things heal, so I think one should stop.
That's a very pertinent point. वो डूबते को तिनके का सहारा है, थोड़ा सा thrombus, some vasospasm has led to sealing of that, and your nitro has again rushed the blood again, and very good point. I think very good case. Thank you very much. Let's move on to the next case.